So associations with emergent resistance, prolonged use of an antibiotic. The longer they're on the antibiotic, the greater the likelihood that you're going to get more and more resistant strains. And in the beginning, it's going to be selection pressure, but over time, you may be selecting out different point mutations that can actually lead to resistance. Associations with emergent resistance, we do know, and people will often talk about this, because we have data with doxycycline being used for 2 weeks versus placebo, where you select out resistant organisms and then stop the doxycycline or the placebo, and you see that the levels of the resistant organisms of doxycycline persist significantly for the next 2 weeks. But what happens after that point? Do they go back to where it is in baseline? Do the resistant organisms disappear and you go back to the baseline? We don't exactly know, but we do know with macrolides that there is a significant persistence in some cases, especially with clarithromycin, more so than azithromycin, though it can still happen with azithromycin, that 6 months later they'll still be colonized with some of those resistant strains that occurred during the course of therapy. So we definitely need a lot more data on this. So knowledge of antibiotic use, and I'm going to be wrapping up with just a couple of different points. We don't have a lot of information in dermatology about if we're treating a patient for acne, let's say, and we're putting them on topical combination with doxycycline or minocycline, for example, or tetracycline, whatever, doesn't matter. You're putting them on an oral antibiotic and maybe even a topical antibiotic, hopefully not unopposed, at least by benzoyl peroxide, which can help to some degree. What is that going to do to that patient if they get sick later on down the line when they expose to the antibiotic? We don't have this data in dermatology, but I think we can at least infer partially what our colleagues have done with pneumococcal infection and to see what happens to those patients if they've been on an antibiotic within 3 months before. So these are patients that came into an emergency room. They were diagnosed with invasive pneumococcal infection, and they looked at risk factors for antibiotic resistance based on a model that they evaluated. And what they showed was, this is the relative risk of infection with a penicillin-resistant pneumococcus based on prior antibiotic use. So if the patient was not previously on a penicillin, they had a very low risk that that pneumococcal infection was going to be resistant to penicillin. Prior antibiotics, but not penicillin or prior penicillin, was about the same, okay? So the relative risk was about 2.5 to 3 times higher that the antibiotic they were on, they would be resistant to when you were treating them. So they teach their residents and their fellows, if they were on an antibiotic within the past 3 months, you don't give them that antibiotic because they're likely going to be resistant to it with the infection that you're treating within that 3-month period. I think that's very revealing information. It's even worse when you start to get to a drug like azithromycin. If they were on azithromycin within 3 months before, they have a 10-fold higher risk that that pneumococcus was resistant to azithromycin than if they weren't on it. Okay, so we're seeing examples where the recent antibiotic use affects what the response is for that infection. And then it wasn't surprising to me that quinolones, especially levofloxacin, which is commonly given out, was 12-fold higher. So this is significant data, and I think we need more information on this in dermatology. So data from the United Kingdom just showing that if you reduce, and I know we have a limited time here, but if you reduce antibiotic exposure, you reduce the resistance in the communities. And in the United Kingdom and even in the United States, other specialties have really cut down. And this is pediatrics, where they're at even higher risk. If a kid comes in with a hot ear and you're thinking, well, I think I'm going to hold off, the risk is at meningitis. And they still decreased by anywhere from 16 to 25% in pediatrics, their antibiotic prescribing in the US. So that was somewhat impressive. Now, has it changed prescribing patterns? In other countries, they've correlated primarily with macrolides. When they've reduced the number of antibiotic prescriptions or exposures in their community over a period of years, 2, 5, 7 years, the resistance rates go down. What they don't tell you is what they switch to. So we know that if we reduce a certain type of antibiotic, we can reduce the resistance, but we have to offer people other options.